Good morning, good afternoon, good evening. This is Dr. Sascha Jovanovic from Los Angeles, and today I am going to discuss with you and present to you an, I think, great topic because it's something that we're dealing with like every single day when we're in the office. Extraction sites. How do we manage them? So in this lecture, I, of course, will focus into like just managing a socket. What's the best way to prevent resorption, to maintain and preserve stability of tissues, and how to incorporate dental implants into the site and actually make them really very, very stable and healthy and aesthetic. So first of all, extraction site management. We can use socket grafts. We can use GBR grafts. We can use soft tissue grafts. And of course, we can use a combination of all. Implant placement can be done at different time points, can be done immediate at the time of socket preservation or at the time of extraction. It can be done delayed, and it can be done in a healed site when all the tissues have stabilized. So let's look and see what we do. So first of all, we need to realize that when we're looking at periodontal tissues around natural teeth and roots, like I'm describing here on the left side, this particular patient, as you can see, has beautiful gingival symmetry, has beautiful health, and has no gingival recession, just beautiful mucogingival tissues. But at the same time, you can see how thin the tissues actually are, how minimal the thickness is, and how pronounced the root contour of these teeth are, or these roots are, in the site. Now imagine that one or multiple of these teeth gets removed or gets lost. What will happen when we just place an implant? Now, on the right side is actually an implant case. It's not the same patient, but you can see that in the total rehabilitation of this patient with dental implants, with a bone and a soft tissue augmentation, with a custom abutment, and of course with a well-emerging ceramic crowns, we actually are able to preserve everything that it looks as natural as possible, but it's thicker. So this is, of course, the goal that we have, is to maintain the look of a patient in the same way the natural teeth were, have good gingival symmetry, have stable bone, and of course have no recession, that the natural tooth appearance seems very similar to the crown that we're placing. Now, when a case is not worked up properly, you can see that on the left-hand side, you can see actually then how an implant was placed for a central incisor replacement. That would be like number 9. And when you look at the CT scan on the left-hand side, you actually can see how the implant either was placed somewhat outside of the bony envelope, or possibly that the buccal bone plate resorbed. The consequence of this, as you can see in the clinical photograph, is that the tissues are extremely thin and the titanium of the implant is shadowing through, and actually also partially here at the cervical margin, part of the implant is already protruding through the tissue. So it has opened up like with a little cleft here, a little fistula, the tissue. So this is kind of a really poor example of an implant placement into a socket. On the right side, again, the same patient you just saw, which would be the correct way of treating it, where you can see like that the implants are placed. On the radiograph, you can see the very stable bone at the crest of the jaw, very stable bone around the neck of the implants, even somewhat superior to the neck of the implant, and this all makes, of course, for a really beautiful soft tissue support. Now, I'm just giving you some examples, right? Because you could say, well, in which indications can I do this? And in which cases can I be stable? Well, the truth is that from research and from scientific documentation, and from my personal experience over many years, you can treat patients flapless, which means like basically removing a tooth and a root and then placing an implant immediately into the socket, as long as you also preserve the site, so you support the buccal bone plate, you then add at the same time a soft tissue graft from the palate, as you can see here, and then you finish the case on that day with a custom abutment with a temporary crown, and then after the appropriate healing of the bone graft and of the soft tissue graft and of the implant osseointegration, we proceed to the final crown. Now, in this particular patient, you can see this is 5 years post-implant placement, flapless, with a socket graft, with a soft tissue graft, with an immediately placed custom abutment, and a temporary. And you can see in a high gingival display, this crown looks pretty much like a natural tooth, which you can see adjacent to this crown. And here you can see a close-up view, again, of a periapical x-ray, and you can see how the implant is maintaining crestal bone. You can see here the custom abutment, how well it's emerging from the implant, narrow at the tip of the implant, not the tip of at the crest of the implant, and of course then here the crown cemented on this site. Immediately you can see here a video just so you can see what we have to do to make these cases successful. This video is also in the guide library, and you can see here quite a nice demonstration of a tooth which has a large internal resorption. We first proceed with a very atraumatic extraction. Then we're choosing the bone site which is appropriate for implant placement, and we're also making sure that the buccal plate is intact. You see the drilling process. This can be guided. This can be within a digital planning protocol, or it can be a laboratory fabricated acrylic transparent guide with the full contour of the tooth in place. We're limiting the drill size with the main goal to really get a nice stability of the implant. Nice stability is about 40 to 45 Newton. And in this particular case, we're utilizing a Noble Active implant, which of course gives us an opportunity to get really a very nice and stable implant position. Here you can see the gap. The implant is placed again approximately 3 millimeters from the crest of the gingival margin on the facial. You can see the gap between the buccal titanium surface and the buccal bone plate. This gets filled with a bone substitute because the buccal bone plate is intact. And you can see here how actually we have a nice condensation of that bone. Already it's soaking in with blood coming from the socket, so it's a really nice vascularization immediately. Then we're supporting this treatment with a connective tissue graft harvested from the palate. This can be from the palate, this could be from the tuberosity. We're making a small tunnel on the facial just so we can place the connective tissue stable with some sutures into the site. And you can see how actually the connective tissue graft is sutured right between the internal side of the buccal soft tissue flap and the abutment. So you don't need to go where the bone is, you just need to be supracrestal. This is the immediate custom abutment, zirconia, with a titanium insert, and then here the acrylic restoration, which was already pre-made. After about 4 to 6 months, we check the healing of the site. You can see actually the mucogingival line has perfectly been preserved. So we can now proceed to the final crown, which, as you can see here, we maybe adjust a little bit the prep margin, but sometimes it just works. And then we made a veneer on the natural tooth, and we made a full veneer on the implant abutment. And you can see a very stable amount of bone after 1 year, and stable gingiva. So that's kind of, the protocol for a flapless case. Now, the next procedure is when we have to deal with situations where it's difficult to place implants. And sometimes it could just be a challenging site. You don't want to take the risk of placing an implant at the same time, so you just want to do a socket graft immediately. You can also place a socket graft and an implant delayed. So that means like you remove the tooth and the root first. This usually has to do when a patient has no soft tissue in the facial, and internally the buccal bone plate is also resorbed. So then we remove the tooth and we allow the soft tissue to heal in, close the site, and this can be helped, if necessary, to thicken the tissue with a soft tissue graft. So on the left photograph, you can see here the just extraction and a socket graft with a seal. At the top site, you'll see a seal with a collagen mucograft. And on the bottom, you can see a socket graft in a molar with a seal, which is a PTFE membrane, a cytoplast. So we have these different options that we can do for patients. And obviously, we always want to think about what's the safest from a clinical standpoint and for the patient, and what's the most biologically accepted for patients. Here you can see again a process of timing. So when we go first into when do we place implants, right? So that's a big question always. Well, if you choose to place implants immediately, you really basically have two options. One is on the top left side, so that's this area here. Again, the buccal plate was intact, the soft tissue was intact, no recession. So here we place the implant directly with a socket graft and also with a soft tissue graft to thicken the buccal soft tissue. On the bottom of this immediate site, you can see something different. I had to raise the flap because the buccal plate was not in existence. But what I chose to do is, because there was sufficient apical bone, there was sufficient palatal bone, and I could place the implant quite safely and in a really optimal position, straight up and down. I placed an implant and placed now a bone graft following the GBR principles, layering technique covered with a resorbable GBR membrane. Now, because a flap was elevated, also here in these immediate extraction sites, I add a connective tissue graft from the palate, but the only difference is with the implant positioning is that in these kind of patients, the connective tissue graft has to be submerged completely. So you're dealing here with a patient who actually has a connective tissue graft harvest on the palate, could again be from the palate or from the tuberosity. For these cases, which I submerge and they're laying on the membrane more like a saddle, I actually prefer the palatal connective tissue graft. It's a little bit more fatty, so it kind of wraps better around the site. And this is just before submerging. Now, the second time point is the delayed one. I discussed it already a little bit. So what we here always want to do is recognize that the site is too challenging to place an implant, and the site also doesn't have enough soft tissue to place a bone graft, either a socket graft or a GBR bone graft. So what we do here is quite simple. No big deal. We remove the root, the tooth. We clean out the site from any granulation tissue or infection tissue. We make sure that there's sufficient vascularization, so bleeding, and we let the soft tissue heal and close over the site. The only difference is you might, and you can, if you want, add a soft tissue graft at the crest, just so you get a thickening and a preservation of keratinized gingiva. Here you can see the difference between top and bottom is that there is no keratinized tissue here. I removed this root, then I grafted the site just with soft tissue, no bone, and you can see the thickening of soft tissue and the keratinized tissue. When we go to the right photograph, this is a completely different story, because I have decided that the socket graft can be placed. So I have sufficient bone to place a bone graft, but I cannot place an implant. So if I place a bone graft immediately at extraction site, I really have no option than waiting 4 to 6 months for that bone graft to heal till at what point I can come back to place an implant. Now, in the photograph, you can see just like two different cases, which I already showed. The main thing is when you do a socket graft like this, is that you want to have some kind of material that it stays in place. And the material can be resorbable, can be non-resorbable, or it can just be the flap that you're advancing and get primary closure. The difference between these flapless approaches, like you see here on the right side, and the flap closure primary, is of course that the primary flap closure always is asking and requesting for vertical incisions, a full thickness flap elevation, and then a periosteal release so you can coronally reposition the flap. So it's a bit more advanced and a bit more traumatic to patients. Now, when we look at scientific documentation on these time points for implant placement, it's interesting because if I look at immediate and the success rate of implants in implants that are placed immediately at extraction site, it seems to be, at least in this clinical documentation, very high, 100% success, but it's a short follow-up. But other documentations have shown that, and I can certainly support this in a well-selected and let's say, healthy patient. Now, when we go to the delayed side, it's interesting. Here, paper, which also shows 100% success of implants over long term, but longer term, 2 to 4 years. So there seems to be no difference in survival rate and success rate in implants. So you can place immediate, you can place delayed. They both do very well. And then when we go to the healed site, so 4 to 6 months later, they drop a little bit in this in this clinical documentation, but it's statistically not really significant. So it's also very high. It's a bit longer follow-up, 5 years. So the conclusion here is that implants in relationship to timing of the extraction site can safely be placed at an immediate extraction socket, at a delayed extraction socket, or at a healed extraction socket. And it depends really more on the case selection and what kind of protocol you will do. So you are the one who is in charge, and not that like you're looking at an extraction and say, oh, I'm going to just place in every one implants because I have 100% success. No, it's really depending on the clinical condition. So here is just as an example for you, and I love to show these 3 cases which are out of my patient pool because they're all anterior aesthetics, and of course you can see a beautiful gingival symmetry. But the time point of the implant placement was 3 different times. On the left is an immediate implant placement at socket. At the middle one is the delayed one. So I waited about 6 to 8 weeks and then placed the implant. And on the right one, I waited about 4 to 6 months and then I placed the implants. Now what's amazing, if you look at it, and if you wouldn't know these time points, I mean, you could come up with any answer. You could say, oh yeah, all 3 cases were done immediate. Or you can say, oh, all 3 cases were done delayed. Or all 3 cases were done healed. So it's kind of, it's possible. But my conclusion after many years is that if you understand the socket, and if you understand the tissues, so the bone and the soft tissues, you can actually really pick the most successful treatment protocol for your patient. And that's, of course, what you see here. Now, the socket grafts, as you can see here, are something that you can do when you have the buccal plate intact, because that functions more or less like a GBR graft. The GBR grafts are usually done when there's no buccal plate. So you can see that in the CT scan. So the buccal bone plate is the deciding factor, really, when you're choosing between a socket graft versus a GBR graft. So that's kind of really important for you to remember. So on the socket graft side left, you don't really need a membrane because you have really the buccal bone plate intact. Now here you can see also the treatment. So on the socket graft side, you can see you can do an immediate implant placement like I showed you with an immediate abutment placement. And on the GBR graft, you can see the idea is always that you can augment the bone in a safe case. So this is immediate. And then you can place bone in a membrane. And of course, Normally we place also a connective tissue graft, but you have to do what you see on this lower right photograph. You have to primary close it. So that means you have to make long vertical incisions, and you have to do a full thickness flap on the buccal, and at the base, internally, you have to cut the periosteum so you can actually get really a nice transfer of that buccal flap in a coronal position, and you can suture it towards the palatal flap. So, extraction sockets, it's all about the buccal bone plate, and of course of the other bone sites, crest that are around the socket. So like, you have to think about a mesial, you have to think about the distal, you have to think about the palatal. And in general, the distance from the gingival crest, buccally to the bone crest, needs to be within about 3 millimeters. Anything which is further than 4, 5, or 6, you obviously can have very easily with implants a recession. So those cases then need to be pushed towards GBR bone grafting, because that gives a much better type of application. Now, interproximally, you have a little bit more distance because you have the interproximal bone peak, and on the palatal, again, it should be somewhere around 3 to 4 millimeters. So this is a nice paper from Boozer from the University of Bern, one of our really top researchers and clinical evaluators. And what he looked at with his team in the CT scan is how thick is the bone actually around anterior teeth. And it's very, very surprising that in an anterior teeth, and it probably also depends on male versus females, and it also depends probably on the ethnic background of the patient. For example, from my experience, Asian patients always have thinner tissues, soft tissue and bone, than white Caucasian patients. So that kind of makes a difference too. But in general, as you can see here, about 90% of patients has really very thin tissue, which is about 1 millimeter or less. So you have to really think about that. So this is one of the many clinical scientific reports, which was then supported with an experimental research in a dog setting. And what you can see here on the facial is as soon as this bone on the facial is evaluated carefully, and just look at the buccal bone versus the lingual bone, how thin this is. This is about that 1 millimeter. So when you remove this tooth and root carefully so that you don't break that buccal bone, you're placing an implant, as you can see here. Sorry, you're not placing an implant. You're actually not doing anything. You just let the bone heal and the soft tissue close. You can see how you get this collapse. And the researcher here, Jan Linde, called this bundle bone, which then basically gets resorbed in a few months after extraction. But if you fill the socket up with a stable bone graft, and in this case, a bone substitute was used, which was a hydroxyapatite, bovine hydroxyapatite, BioOs. And you can see how actually the buccal bone is well preserved, and also the crest is well preserved. So it behooves you, and it behooves the patient, to get a socket graft into the site, especially when you're dealing with thin buccal bone plates, and especially when you're dealing with patients who have, of course, an aesthetic concern. Now, what about soft tissue? I mentioned that earlier, and I just go straight here, as you can see in the clinical photograph, how in many cases, for the last 20, I would say 25 years almost, I've always added connective tissue grafts to these sites, especially when it's anterior, again to thicken tissue, because you can see the headliner at the bottom. Mucosal thickness affects the marginal bone stability positively. So you have to think really that you're dealing with soft tissue grafts, which actually can promote and stabilize crestal bone. And thin soft tissue can actually create and promote risk for bone resorption. So this is really important because a lot of aesthetic implants are getting placed without a soft tissue graft. So that's really something you have to be careful with. And here you can see how more bone resorption and a more apical soft tissue position can be expected when implants are surrounded with thin mucosa. And this is the key, independently of the thickness of the buccal bone crest. So you are getting more resorption risk of bone if you have thinner soft tissue. Very, very interesting. Now here I put another clinical documentation, which was published in 2013 by an Italian group, and it basically went into what should we do after extraction? So we add a soft tissue graft like I'm proposing, or should we just leave it without? Well, also this particular group came in two groups that they randomized, clearly to the conclusion that if you add soft tissue, and you can add soft tissue like you see here on the left side, just by adding a little soft tissue plug between the buccal tissue and the implant abutment. You can add a little tunneling connective tissue graft, or you can add soft tissue seals at the top of the crest. All these three options actually give you really a nice type of feeling of what you can and should do in patients to improve the success rate. Again, you want to get better thickness so you can affect more positively bone stability. Now, in normal sites, right? So like when you think about soft tissue dimensions, we're actually lucky because up to now I talked about thickness, which is very important. But when you just look at the height, so where's the gingival height of soft tissue and how does that relate to the underlying bone? And it's interesting that there is a soft tissue dimension which is biologically very stable. So the height itself, I'm not talking about the thickness, the height itself seems to be 3 plus or minus millimeters, and independently from what kind of abutment you use or from what kind of connection you use. Of course, that's the biocompatible abutment. And now, but you have to think that this 3 millimeter soft tissue height is going to be affected again by the thickness. So it might be 3 millimeters in the beginning, but it can produce some bone loss if it's not thick enough to get again to some recession, and then it starts to develop the 3 millimeters again once it gets thick enough. So height and width are related, but like the height is usually very stable at about 3.5 millimeters. So that's why we can use that rule, clinical rule and clinical protocol very well to place the implants always 3 to 3.5 millimeters below that ideal gingival margin. Of course, we support them with bone and with soft tissue. Now, these are the options which we're dealing with in sockets. And we're just looking at bone now again. I have 3 options really that I have to kind of discuss with my team. And then, of course, I have to present the plan, the treatment plan to the patient. If the socket wall is intact, right? So like I have buccal bone, as you can see on the left side. I can, if I want to, place an implant if it's safe. I can place a socket graft and just preserve the top, probably with a soft tissue graft. And I place an implant 4 to 6 months later. So it's a very atraumatic procedure because I don't need to raise a flap. In the middle photograph, you can see that there's a moderate amount of bone missing on the buccal. So, but there is not enough bone. But all the other bony sites are intact, interproximal and palatal. So now I can actually, if I want to, still do an immediate implant, but I have to raise a flap so I can access the site, I can see the site, and I can place my implant and my bone graft and my membrane and my connective tissue graft all at the same time. And then I have to raise the flap and do a primary closure. So it's a lot of work all happening in one site, so it's also a little bit more risky. Class 3 is when you have really a lot of bone missing on the facial. You wouldn't want to place an implant immediately because it's too compromised. There's maybe also some bone missing on the palate. So what you do here is I would take this particular patient, do a delayed healing, so improve the soft tissue, so I get nice primary closure. And then after about 6 to 8 weeks, I come back, place an implant. Now I know I have bone missing. I do a nice GBR bone graft, again, in addition with a soft tissue graft possibly, and I do a primary closure for normal bone regeneration and osseointegration, which takes about 6 months. So that's really like my ideal in this particular patient. So the second situation, of course, you have to think about is the soft tissue margin. So when you look at the left photograph, a lot of pigmentation here, but the mucogingival line is perfect, no recession. So this is really intact gingiva. The second, the middle one, you can see recession. You can see the root of the teeth which have to be extracted. But this patient still has keratinized tissue. So there's no mucogingival problem. There's just a mucogingival recession. The third case on the right side is much more problematic and much more challenging because you're dealing here with a mucogingival problem and recession. So the difference between the second and the third class for me is that the second one I can actually still treat immediately if I wanted to, because I can raise the flap and basically coronally reposition it. And underneath it, I could have an implant, a GBR graft, and a soft tissue graft. The third class is much more complicated because I have no tissue. So here, for sure, what I would do is just remove the root, again, get sufficient blood supply in there, get a lot of like cleaning, use a lot of like, kind of stimulus of the bony walls to get blood in there, and then just let the soft tissue heal. And then I come back 6 to 8 weeks later. So I don't place a socket graft because look, I have no soft tissue in there. Now, there's another area of implants that you have to think about is how does the bone relate around the root in the future implant placement? Because roots can be at an angle in the bone. Implants usually straight up and down or maybe a little angulation, but really in an aesthetic case it's not that ideal because angulated abutments always give you a little bit of compromise in that kind of steep angle. So class 1, again, like you see here in the left photograph, is ideal because you can see how the implant would just follow the trajectory of the root. And you got palatal bone, you got apical bone, you got buccal bone. The second class is already more difficult because once I remove this tooth, I can't really go and follow the trajectory of this particular root without perforating apically. So this will be a GBR for sure. I can maybe angle it a little bit, but then I have to use a restorative modification. So it just depends a bit what you would like to do. And the third one is pretty easy to say. We can't do that because look, where's the implant going to end up? It's going to be like just pressing through that buccal plate, and it'll be very, of course, like impossible to get a good result here. So this is easy. You remove the tooth, and depending on the case, I could do maybe GBR right away if the soft tissue is good to make a primary closure, or I wait 4 to 6 weeks and I do the GBR then. So think about really the anatomy of the alveolar process. Where's the palatal bone? Where's the buccal bone? Where's the apical bone? And how does the root of the tooth differ in position with the future implant? Because the future implant has to follow the crown emergence, especially when you're dealing with an aesthetic case. So class 1, class 2, and class 3 are important. So here's then like the class 1 scenario. On the left photograph, I'm showing here great soft tissue, no recession. The probe demonstrates to me that the crestal bone is 3 millimeters below the gingival margin. The CT scan shows me that there is bone in the buccal. Thin, but there is bone. And the right photograph just is in histology, which of course we wouldn't have on a patient. So this would be an ideal case if I wanted to do either an immediate implant with a socket graft, or if I'm a little bit more conservative, I can just do a socket graft with a soft tissue seal on top. So this is kind of really an ideal case for an immediate implant. So how do I remove roots carefully? Well, I'm a big supporter of the atraumatic extraction. So microsurgical work has to be done here because roots if you're not done carefully, you can damage the soft tissue. You can also damage the bone. And of course, you can fracture roots. So one of my preferred ways of using piezo surgery, and I use the Mectron device, and I just use the little knife, which is the periotome, and I go into the space between the root and the bone, so into the periodontal ligament space. And that loosens the tooth, and usually I can remove any kind of root really carefully, even molars. A second extractor is this a German-made extractor. The Mectron is from Italy, so a European device. The Benex is a German device. It's basically like a cork screw removal of a root, so it's kind of the same idea. And it works really like this, as you can see. You turn, after a small drilling process in the root, into like usually the nerve canal, you turn this like little cork pull device into the root, and then you have like a little device which kind of you turn, and then it pulls the root straight out. So it's kind of very efficient in its application. And here you can see it. I'm first like probing the tissues. Then I'm cutting a sulcular incision. Here's the piezo surgery then, going straight into that periodontal ligament space. Very, very nice, because I'm loosening the root. You can see I can go quite deep in there. And now I'm showing also the Benex extractor. You use first like a 1mm drill. Then you turn it in with your hand, and then there's also like a little device, torque wrench you can use. You really want to make sure that mechanically it's stable in the root. Nice and stable right now. And there you go. I attach this, it's like almost called like a torture device. Here's the Benex extractor. Here's the device, which is kind of very efficient, really German made. And then you're pulling it out and getting it into the right side. It takes a little bit of time. You have to really like place it on the teeth so it focuses well. And here you can see how the root comes out without damaging any of the bone. Beautiful. Look, that's great. Very, very nice. Straight out. And now, of course, you have buccal bone. You have all the bone. Now you're cleaning it, so you have enough blood supply. Then you could even activate a little bit by the drill, so you can have enough bleeding for the next step, which is the socket. So let me present you then with a decision tree. So I'm going to start first with the very simple cases, which is basically posterior non-aesthetic zone. And I've decided to remove the teeth and the roots, and I've not decided to place implants. Just like it's too challenging, there's not enough bone. I just want to preserve the bone and get the site ready for an implant. So I'll do an immediate socket graft. So you can see that here the decision tree goes from an posterior, usually a premolar or a molar, limited bone volume, goes into immediate, but not immediate implant, immediate socket graft. And I can use here a xenograft, so a bovine hydroxyapatite, or a mineralized allograft. Now the three options I have is to do a full flap closure. I can place a collagen native membrane as a socket seal, which is this one. That's a mucograft. Or I can use, which is very efficient, a dense PTFE as a socket seal. I like this one also very well because it's really a mechanical stop of movement and losing any tissues. So here's the three options I have put together. Left is the full flap closure. So I just need a bone graft. I don't need a membrane. So it's also less costly to the patient. But As you can see, you're displacing the soft tissue margin. There's sutures which are involved here. And of course, also there is some bleeding that's involved and maybe some swelling. On the middle photograph is the natural collagen membrane, the mucograft. So that will just resorb by itself. And on the right side is the PTFE membrane, the cytoplast, which is very efficient here, and it will stay in position. So here's a flap management case. If you look at it, on the left photograph, you see the crown and the root canal, and then the fracture that this patient had. So I removed the tooth, the molar. I can always make a hemisection that's really efficient. I can use again the piezo surgery, and you can see that the middle septum is really, really thin, and the mandibular canal also is not too close, but not super far away either. So I can find it so much more controllable just to raise a flap, place a bone graft, and come back 4 to 6 months later. So here's the bone graft placed in this photograph. Here a bovine hydroxyapatite. Here you can see it sitting nicely in the roots all the way to the crest. And then here's the full flap closure with a displacement of the mucogingival line a little bit towards the lingual. But I can correct that later. So here's the 2 weeks healing. Absolutely perfect. I didn't need a membrane here because I'm just waiting here for the socket to fill. Maybe I get a little bit of soft tissue invasion, but it's not a big problem in these posterior cases. And we'll let this now heal for the patient. So usually I wait about 4.5 to 6 months. And then you can see how I made my flap because it's really nice healing. Got a lot of bone here in this particular patient. I'll make the flap incision a little bit on towards the lingual, always staying in keratinized gingiva, so I can displace the flap to the buccal. Now notice my incision is crestal around the tooth and the premolar and the molar, and then it's a full thickness flap. And then I follow the drilling protocol of the implant system that I'm using. Here I'll use like a pretty passive implant. I'm not going to do immediate temporization. I go very nice and, just normal routine. And I'm placing here an implant at bone level. So this in the molar will probably be a 5 millimeter diameter, conical connection. Here you can see it. And then I'm connecting this with a tissue level abutment. It's called an on-1. You could also use a tissue level implant, of course. And there's a healing cap. But the nice thing about this abutment this short abutment, is that it has this little nice emergence, so there's no pressure on the connective tissue. And the implant is placed, the abutment is placed, so we made a tissue level, and it's per gingival already. And then as you can see, I'm placing the sutures. These are nylon sutures, 5-0. And I got beautiful keratinized gingiva on the buccal. I got nice keratinized gingiva on the lingual, so no problems from a standpoint of healing. And here you can see the radiograph, which shows really nicely how the abutment gives you this really nice emergence from the conical connection. So there's no pressure on the bone, there's no pressure on the connective tissue, really nice and preserving all the tissues. So it's important to know that this platform now for the future crown connection is taken higher up. So it's really away from the implant connection. So this will preserve the bone and preserve the soft tissue much better. This is the 2-year follow-up. Don't ask me why the patient didn't do the crown. I really don't know. But she came back 2 years later, and it's amazing to see just how beautiful the soft tissue. She just kept cleaning it. And, maybe she came back because the posterior crown came off. So she said, it's probably time to do this. And then we did this here, as you can see, after 2 years. Here's the crown. It's a little bit short because the patient had a small intermaxillary space, but very healthy, very well positioned. And this abutment is connected to the crown also with a pretty good screw. So this is screwed into position with 35 Newton per centimeter. We left the space open towards the posterior. The patient was supposed to, or will be supposed to, replace that posterior tooth also with an implant. So we're just waiting for her to make that decision. And here you can see the implant look at the beautiful preservation of bone after time, the abutment we made the tissue level, and then the final abutment to connect to the crown. And here's the before extraction with the xenosocket graft, then the implant and the tissue level abutment, and then the final crown for this patient. So one of the other options you have is like to use these non-resorbable materials, which you can see the cytoplast. So this is always in socket preservation with xenograft or allograft. And then we do this flapless buccal and lingual tunneling approach, and then just kind of slide the membrane underneath the buccal and the lingual. So that's really nice and efficient. So here's a patient. On the left photograph, you can see the tooth, which has to be removed, the molar. There's a furcation involvement. There's bone loss. It's the posterior. So I removed the tooth, then cleaned out the site, removed all the granulation tissue. Again, got nice bleeding. I placed the bone graft here. In this case, I used a mineralized allograft. And the main reason was just because there was maybe still some remnants of the bacterial content there, although I cleaned and irrigated it well. So I wanted something which possibly could resorb if needed. And then you can see how I used the cytoplast to slide it buccally and lingually under the flap. Some sutures to hold it in place. And then 14 days later, you can see the sutures are still beautifully in place. But you see the patient was maybe not the best one to keep it clean. So you can see already some bacterial content on top. But the patient was washing with chlorhexidine the mouth. Then 14 days, remove the sutures. 30 days, you can see the gingival margin is really very stable, very in the same position. And then we just like took a plier and pulled it out. And you can nicely see in this last photograph here how where the bacteria were sitting on top, and this was in a tunneling site, how clean this is underneath the tissues. And here is the new osteoid tissue, also some granulation tissue at the top, and this will just granulate in for the patient. 6 months later, look at the bone. Probably this photograph shows it really nicely. There's a little bit of buccal resorption because remember the patient had that furcation, but a lot of new bone here. So that's good for the implant. And of course, I have a lot of buccal lingual width to place the implant. And that's what we did here. So basically, I placed here an implant now after 6 months, and I did tissue level also at the same time like the previous patient. So that's really efficient. Here, a very similar case. So this is like really standard treatment in my practice. Patient lost this molar. We had to remove it. So you can see the removal of the mandibular molar. Same scenario like for the maxilla. I placed here a mineralized allograft, placed the cytoplast, tunneled it under the buccal, tunneled it under the lingual, and then you can see the healing. This is the suture removal after 15 days. You can see how the membrane is still very nicely intact. This patient was cleaner, who's a female. And 1 month later, I removed the membrane, and you can see how the soft tissue is really nicely creeping into the site here. This is 6 months later. It seems to be, again, a little bit of buccal collapse here, but bone-wise, the patient had enough. So, here, if we needed to, we could have always like added some soft tissue graft at the time of implant placement, or even like a little bone graft, just to get that contour right. Here you can see the patient's CT scan, a lot of bone, really good. But here you can see how there's a little collapse in this area. Implant was placed, again with an perigingival abutment. And then the patient received a full zirconia crown with a titanium base. So it was like a one-piece screw-retained restorative solution for this particular patient. This is the 2-year follow-up. Excellent result. Just see a little bit of that collapse on the buccal. That's the 5-year result on this patient. You can see the titanium insert, and the rest is all zirconia. Again, we're keeping it always nice and narrow at this top part. And then you can see the 5-year result in this particular patient. So this is kind of, the way that we're managing these patients with the cytoplast. I will stop here and allow the next lecture to go into the next topics of extraction sockets and how to manage them. So thank you for listening. Thank you for taking first the attention, and then to be followed in part 2 of extraction sites.